Welcome to this video on abnormalities of the fetal anterior body wall, including defects of the abdominal and chest walls. In this session, we will guide you through the most important congenital defects of the fetal body wall seen on prenatal ultrasound. Two of the most common ventral abdominal wall defects are omphalocele and gastroschisis. Then there is bladder exstrophy, which results from a defect in the lower abdominal wall. Afterwards, we will discuss more complex fetal body wall defects, such as pathology of Cantrell, body stalk anomaly, also known as limb body wall complex, amniotic band syndrome, and Ease complex. You'll learn key definitions, ultrasound findings, and clinical clues to help you accurately identify these conditions. Understanding these wall defects is vital for effective early diagnosis and optimal pregnancy management. Omphalocele can be diagnosed as early as 11 weeks if herniation is larger than 7 millimeters. AT-S, an anterior abdominal wall defect where bowel and other organs herniate into the base of the umbilical cord. The herniated organs are covered by a thin membrane made up of amnion outer layer and peritoneum inner layer, and the umbilical cord inserts into the mass. Ascites may be present both in the omphalocele and inside the fetal abdomen. Involvement of the liver in the sac is linked to a poorer prognosis. Omphalocele carries a higher risk of heart defects, chromosomal anomalies, and syndromes compared to gastroschisis. Finding an omphalocele should prompt thorough evaluation for additional anomalies, including a fetal heart scan. Omphalocele needs to be differentiated from pseudoomphalocele is a temporary bulge in the fetal abdomen caused by external pressure from the transducer, fetal limb, or uterine contraction. The bulge is covered by intact full-thickness abdominal wall, unlike the thin membrane in true omphalocele. The bulge disappears once the pressure is relieved and the abdomen returns to normal. It's more common in the third trimester due to reduced amniotic fluid, making the abdomen easier to distort. Gastroschisis is a lateral, full-thickness abdominal wall defect usually to the right of the cord where small bowel herniates and fluids freely in amniotic fluid with no covering membrane, caused by a vascular incident affecting the right umbilical vein or omphalomesentéric artery. Cord inserts normally into the abdomen. Defect is separate and to the right of insertion. More common in babies of young or teenage mothers. Incidence is rising due to environmental factors like smoking and drug exposure. Only small bowel is involved. Liver and stomach are not herniated, unlike omphalocele. Free-floating bowel appears cauliflower-like and may look echogenic from edema or inflammation. Bowel loops can be dilated due to obstruction or umbilical cord can sometimes mimic bowel loops but can be distinguished by color Doppler showing blood vessels. Risk of chromosomal abnormalities, aneuploidy, is not increased. Elevated maternal serum AFP is seen in both gastroschisis and omphalocele and helps in early detection. Bladder exstrophy is an infraumbilical defect from incomplete closure of the lower abdominal wall and bladder. Diagnosis relies on failure to see a normal bladder on ultrasound. The exposed bladder may appear thickened or irregular in the lower abdomen. The umbilical cord inserts lower than usual, often associated with genital abnormalities like epispadias bladder exstrophy epispidis complex. Then there is chest wall defect, resulting in a condition named ectopia cordis. Ectopia cordis is a midline upper body wall defect, where part or all of the heart is outside the chest, sometimes with a membrane. The heart usually protrudes through a defect in the sternum, but may also be found in the neck or abdomen. Often occurs alongside other heart abnormalities or abdominal wall defects. Prognosis is poor, but rare survivors exist. Can be associated with trisomy 18, especially if other abnormalities are present. Let's dive into complex wall abnormalities. Pathology of Cantrell. Pathology of Cantrell is a rare condition with 5 features: sternal defect, ectopia, cordis, heart anomalies, anterior diaphragm, and pericardial defects, and a supraumbilical abdominal wall defect, often omphalocele. May also have midline defects like facial cleft or encephalocele associated with trisomies 18 and 13. Genetic counseling is recommended. Prognosis is poor. Body stalk anomaly, limb body wall complex is a rare, lethal anterior abdominal wall defect. Features include a very short or absent umbilical cord, which causes the fetus to lie very close to the wall of the gestational sac. This is a key differentiating point from pathology of Cantrell. Severe defects in the abdominal and thoracic walls, resulting in organs outside the body due to short or absent cord, limited fetal movements, often associated with severe spinal deformities and limb abnormalities like club foot or missing limbs, hence known as limb-body wall complex, caused by early developmental disruptions. Exact cause is unknown. Clocoextrophy, aka Ease complex. Clocoextrophy is a severe defect affecting the bladder, genitalia, rectum, and lower spine, also known as OEIS complex. M. fallicele, extrophy, imperforate anus, and spinal dystrophism. Diagnosed prenatally by finding M. fallicele, absent bladder, and anal dimple, and spine anomalies. Other features include genital and kidney abnormalities, single umbilical artery, and ascites. The elephant trunk sign refers to a prolapsed bowel loop between the open bladder halves. Last but not the least, amniotic band syndrome. Rupture of the amniotic membrane can result in amniotic bands, which may wrap around the fetal body, causing wall defects by constriction, as well as limb amputations and other abnormalities. Amniotic band syndrome can affect any fetal area, sometimes involving the abdominal or thoracic walls. Wall defects may resemble gastroschisis, with organs floating freely in the amniotic fluid and no surrounding sac. Diagnosis is suggested by visible amniotic bands, plus other disruptions like limb constriction, amputation, encephalocele, or facial clefts. The umbilical cord is usually present, unlike in body stalk anomaly. Thank you for watching our overview of fetal anterior abdominal wall abnormalities. By mastering the sonographic features and differences between these defects, you'll improve your confidence and accuracy in prenatal screening. For more detailed explanations, ultrasound tips, and clinical case reviews, make sure to like, comment, and subscribe. See you in the next video.